if you join the community of practice, to be able to see what is going on. And if there's any other questions that we haven't dealt with, you can actually post it there. And then also to have the Social app downloaded to be able to scan the QR codes to get your attestation. And just to emphasize that this attestation only works for this session, so the QR codes can only be downloaded for this session. So I'm going to just quickly share with you the codes as well, so that you can just have a look and to make sure that you can see what is going on. So I'm just going to share with you the QR codes again, so you can just scan it to be able to start. So quickly get to my screen, and then we will be able to start soon. I'm just going to give you a minute just to be able to start with that. So this is the QR code that you can scan, and it will give you the attestation if you scan the N code after the session as well. We did post it on the Telegram, so if you weren't able to do it now, you will be able to do it from the Telegram as well. It is available for today, that you can get your attestation from there. And then if you see, there's the link to get the documents and the resources on the africacdc.org. Under resources, you will be able to find all the presentations as well. Okay. So I just want to again welcome everybody, and I just want to say thank you for joining us again. And I'm going to hand over to Mrs. Izini Onowiki, and I'm not going to try and pronounce her surname because I'm not going to get right with that. So over to you, Izini, to just do us the introduction on the COVID status in Africa. Thank you. Izini,
hi, good afternoon, everyone. Yeah, so I'm going to start sharing my screen. Can you see my screen?
Yes, we can.
Okay, great. So good morning, good afternoon, good evening, everyone. Today, I'll take you through the Africa CDC COVID-19 pandemic epidemiological update as of today, the 16th September 2020. So globally, the situation, the global COVID-19 situation is on the screen, and we can see that globally we're more than 29 million confirmed cases, and as for deaths, we're more than 900,000 and going towards the 1 million mark. And the CFR as of today remains at 3.2%. And if you look at the graph there, you could see that the PAHO region, the Sahara region, and the EMRA region without Africa are seeing the cases continue to spike every day. It's the number of cases, but they are constantly increasing. And can you hear me?
Yes, we can.
Okay, great. And so these data globally, we're getting it from WHO. Then the next slide takes a closer look at the situation in Africa, where we are. And as at this morning, we're more than 1.3 million cases and over 33,000 deaths, giving us a CFR of 2.4%. And on a positive note, the recoveries are at about 82%, which is like 1.1 million recoveries in all. And we can see that from the graph, it appears that the number of cases are gradually reducing across the continent, but you can also see the variations using the 7-day moving average for the different regions, the Western, the Southern, the Northern, the Eastern, and the Central regions. So you can see that it's a bit different in each of the regions. Next, we'll just take a closer look at the numbers by region. So the central region, as of yesterday's data, hasn't recorded any deaths, and we have about 50 new cases. Eastern, about 900 new cases and 16 deaths. Northern, above over 2,000. Southern, about 1,000. So we could see that the northern and the southern regions are reporting the most number of new cases per day, with the northern leading and southern second, and the least is the central. But when we look at the cumulative CFR, we can see that the northern again is still leading in terms of the CFR reason, with a CFR of 3.45%, and followed still by the southern region with 2.38%. And the least is the western region with a CFR of 1.50. So we'll take a much closer look at the continent and countries using the cumulative COVID-19 cases countries have. We see that there are about 5 categories. Only one country has reported more than 500,000 cases, and we all know that that's South Africa. Most countries are really between 10,000 and 50,000 cases, most countries on the continent, followed by others that are below 10,000, but are still more than 5,000. Quite a lot of countries are way below the 5,000 cases mark, about 27 of those. We have 4 countries which are between 50,000 and 500,000 cases. And so the next is still looking at these analysis, but now not just number of cases, but number of cases per 1,000 population. So we only have 1 country not reporting data, which is Tanzania. But with the charts, we can see the different countries and how many cases per 1,000 that they're reporting. We've got 6 countries that are less than 10 cases per 1,000. We have 3 that are more than 500, and South Africa is one of them. And we have 14 countries between 100 and 500 cases per 1,000 population. And so these data, we got them from the official member state reports, and you can also take a look at our dashboard on the Africa CDC website to have more in-depth details on these, on each country. So next, we'll look at the total COVID-19 tests conducted in Africa, and cumulatively, we're at about 13.5 million tests conducted from the 1st of May till now. And this is a 6% increase from last week at the rate we're testing now. And the continent has about 10% positivity rate. So just looking closely now at our webinars, this is a bit away from the epidemiological updates. It's just also nice that we also give some information on the webinars that we have been running. As you're aware, this is the 3rd series, and each series runs for 6 weeks. And we have the English, which we have every Wednesday, and the French, which we have every Friday. And this is the last series for this, the last session for this series. But just know that we are going to start another series in 2 weeks' time. That is series 4. And we'll just take a week in between, and then we'll start another series. So please still join in. And from the data there, you could see we've covered quite a lot of countries. We've trained over 4,750 unique people and had 9,210 total participants. And within Africa, we've covered 42 countries. Unfortunately, we've not been able to reach every country. So there are 13 countries that haven't yet come on board. And we hope that as we continue the series, they will also benefit from these. And you can see their names on the screen. We have also reached 33 non-AU countries, as you can see on the map, which is quite a wide range. And aside the webinars, we've trained all our current volunteers across the continent. Africa CDC has quite a number of volunteers over more than 10, probably about, I think, more than 15 member states. We have volunteers present. We've trained them all on IPC. We've trained staff of the AU Medical Services, as well as all the other volunteers deployed in other countries. So that's all for me for the AP updates. So for more information, you can visit our website. We have guidelines there. We have the dashboard is available on the website as well. All our guidelines are also there on IPC and other areas. And we also have the community of practice, as we mentioned, where you can drop your questions and you definitely get answers to them. And we also drop guidelines whenever they're released on the community of practice. We'll drop a link in the chat box, in the question and answer and chat box, so that you can also click on that to continue the conversation after this webinar. So thank you very much, Anna, over to you.
Thank you very much, Adina. It was great to see what you've given to us. And as we can see that there's at least a decrease, and we can see a lot of people are recovering. So it's welcome news. And it's my big privilege to also welcome now Professor Afolabi from Nigeria. Professor Afolabi is the Professor of Obstetrics and Gynecology. She's trained in Nigeria and the United Kingdom. And she's also currently the head of the Department of Obstetrics and Gynecology at the College of Medicine. And she also sits on the board of several hospitals. She's also a PhD examiner, and a supervisor and assistant editor in the Journal of the West Africa College of Surgeons. So welcome, Professor Afolabi. We are so grateful that you will be able to assist us. And if you are able to share your screen, that will be wonderful. Thank you. Over to you, Professor.
Thank you very much. Good morning, good afternoon, good evening, everyone, as somebody else said. I'm going to try and share my screen, and I hope you can see.
Yes, we can.
Okay.
Can you make it a full screen? Okay.
Okay. So, good greetings to everyone. Thank you. I'm honored to have been asked to give this talk. I inadvertently became the COVID person in my unit when this pandemic started, partly because I'm the head of department, and we were able to make sure that we continued working as opposed to shutting down, as some facilities in Lagos had to. So I'll be speaking today on safe surgery and safe delivery in COVID-19 patients. And I am speaking from the College of Medicine is our background. So I'm going to talk about the current knowledge about COVID-19 in pregnancy very briefly. I'll also talk about preparation, how we prepared for it in the department, then just go to some case reports and and give a few last words. I hope you can hear me.
Yes, we can.
Okay, great. So basically the current knowledge about COVID-19, published data thus far, about 921 publications in the last, as of yesterday. And most infections are in the third trimester. Features are similar to the non-pregnant patients. Fever and cough are most common. There was this study done recently, published just a few weeks ago, about a cohort study on the maternal and perinatal outcomes of COVID-19 and in pregnancy. And it's found that up till now, one of the largest has been followed up, about 388 pregnancies followed up. Most of them have delivered. Most infections have been in the third trimester still. We don't understand why that is, but it's still early days. Features are similar to the non-pregnant, like I said. Most of the patients in pregnancy are asymptomatic, but when they happen to be symptomatic, as in this cohort study, when of those admitted, about 0.8% of them died, but more striking was that about 11% of them needed ICU care. Now, it's possible to look at that and say pregnant women are very, get very sick and have to have ICU care, but we must remember that these patients that are being spoken about here are the ones that had symptoms in the first place and presented in hospital. So it's for symptomatic pregnant women. If they actually do have symptoms, then quite a number of them happen to go to the ICU. However, most pregnant women are asymptomatic and don't present necessarily in hospital. Preterm delivery appears to be more common in them. That's been standard. We found out that most of them, about 30%, 25 to 30% tend to go into preterm labor and have preterm deliveries. We do have quite a few low birth weights as well. Majority of the patients so far with COVID-19 in pregnancy have had cesarean sections, although we have to keep emphasizing that COVID-19 is not an indication for cesarean section, and we've had normal births as well. Transmission from mother to child is uncommon. In the largest series, we've had 4%, and when we've delivered them, we've had no evidence of breastfeeding being a manner of transmission, so we still ask women to breastfeed, and we still ask the women to hold their babies, of course, masked and sanitizing as much as possible. Now, one of the things we did to prepare for safe delivery is to have regular meetings, and from those we drew up protocols. We've even published a few protocols and guidelines in peer-reviewed journals from my department. We also had the luxury of having an infectious diseases unit, as well as a very highly functional microbiology unit in my teaching hospital. So we had good IPC, infection prevention and control training. We did some drills before we had the first patient, and I'll speak to that a bit more later. We tried to encourage leadership by example. So all the consultants and myself as head, I made sure that we all were there for our residents so that they would feel safe, and also seeing the patients at the same time. The management of the hospital didn't forget the mental health of staff, which was very, very key, because we actually had department by department webinars on mental health and how to keep calm during the COVID-19 part. And one of the most important things that we did was to keep communicating and communicating. You know, when WhatsApp first came in, I used to think, oh, for goodness sake, this WhatsApp is too intrusive. I really don't like WhatsApp. I still don't like WhatsApp, but it has been extremely useful at this time. So we had a multidisciplinary team of everyone, including engineers, cleaners, medical records, admin staff, and all the different specialists to help make delivery safe. Now, very quickly, principles of management in pregnancy are like in every other unit. And this is the guideline that we published in my department on the right. Basically, in pregnancy, you must isolate early, do lab tests for the virus and any other co-infection, possible co-infections. For example, the pneumonias that they tend to have at the same time. Aggressive infection control procedures, oxygen, just like in everyone else. Pregnant women also need a lot of oxygen when they have symptomatic COVID-19. Judicious fluid use, so you don't want to give too much intravenous fluid so as not to flood the lungs. At the same time, they mustn't be dehydrated, so we encourage oral fluid intake as much as possible. Antibiotics only if they have a secondary bacterial infection. I crossed out the lopinavir, ritonavir, and hydroxychloroquine because at first we were giving them, but as time went on, since we realized that they are not evidence-based, so they're only being used under clinical trial setting. Dexamethasone was found to be effective, and so we use them in the very symptomatic women. Fetal monitoring is key in pregnancy, as you can imagine, so we had to have things to monitor the fetus when the woman was on the ward. And we also had to individualize delivery planning and advise early ICU and HDU care. The team-based approach could not be overemphasized in terms of delivery. Each woman had to be taken on her own basis. We had 9 COVID-19 positive women who we delivered safely. we only use the obstetric indication for delivery. So unfortunately, 8 out of the 9 of them had cesarean section, even though we say it's not an indication, but they did have reasons for needing the cesarean sections. For vaginal delivery, I've put the mask here because basically for all our patients, we finally got everybody to realize that this is the main thing you need, this surgical face mask. For patients who we don't think have COVID-19, who are not suspected or confirmed, just general patients, we made sure that all the staff had IPC training, the management of the hospital made sure of that. And then we made sure that for our fetal Dopplers that we use to monitor them in labor are regularly disinfected. For the cardiotocograph machine that we usually would strap around a woman with the straps, with the cloth straps, we use plaster, easily remove plaster instead, so that you can throw that away instead of using the regular belts. And for taking a vaginal delivery, the staff just has to have an apron or a disposable gown, a face shield in addition to the face mask, because of the fact that women in labor, scream a lot and might pass a lot of fluid from their nostrils and mouths across. And some people also felt safer with shoe covers or boots. For suspected or confirmed COVID-19 patients, dedicated midwives doing long shifts were what we had in mind to help make this. We didn't really have to have any vaginal delivery in them, which is why we only had one patient that had a vaginal delivery that was confirmed COVID-19. So we had dedicated midwives doing long shifts. We had dedicated fetal Dopplers and CTG to them. And then for the staff, impervious surgical gown, N95 mask and face shield, surgical boots and elbow length gloves. Now, for cesarean section patients, general patients were also usual care because they had spinal anesthesia. So at the beginning, all the nurses in theater and all the anesthetists used to insist on having N95 masks for them. But as time went on, we realized that, look, with spinal anesthesia, there's no risk of aerosolization in theater anyway. So just wear your usual gowns as well as your usual face masks. As time went on, that has been the case. As far as the suspected or confirmed COVID-19 positive patients were concerned, though, we used a pack system for drugs and consumables, so we didn't have to keep going back for different things. We just had everything they needed in one pack, and we alerted the pharmacy to say, look, we have a COVID-19 patient, and they know what they're supposed to put in the pack and transfer to theater. Also managed to plan to minimize blood loss, so we didn't have to keep going back and forth from blood banks. So we used certain pharmaceutical agents that would help prevent blood loss during the cesarean section. And for the staff, they used we advised impervious surgical gowns and N95 masks, face shields, and so on. However, they wanted Tyvek suits at the time, at the beginning, when things were really worrying. But as time went on now, as things go on, we haven't had any more confirmed COVID-19 patients. But now for general patients, nobody is asking for so much anymore, because we know that Tyvek suits are not really necessary. This is an airborne condition, not something that's like Ebola that you be touching, that fluid the carrier. So Tyvek suits are not really required. So this was our COVID-19 maternal health team when we had a set of twins. And this was in the early days, but like I mentioned now, surgical gowns are adequate for COVID-19. You can imagine how hot and uncomfortable these were. Incidentally, I remember discussing with a colleague of mine in Ireland, and she said to me that from the word go, they never use these Tyvek suits because they don't even know how to take them off and on anyway, that they always just use their usual surgical gowns and nobody got infected. Now, just to say a few more words about how we prepared for the safe delivery, we planned that there's appropriate ventilation in the rooms, and if there's no appropriate ventilation, we made sure that we had the appropriate PPE. So for isolation rooms, for holding them before the actual delivery, this is just a diagram where we have, we plan that the isolation room should be at the exit. So if there are two exits in a particular building, you have your entry from one end and you have other wards and rooms around here, and the isolation room itself will be near the exit. I don't have to teach my infectious control grandmothers to suck eggs here, because I'm sure you all know how best to prepare this. But I'm just saying this for people who might not be so aware. And then if you don't have two exits and entries, you can just partition your room and make the flow such that you enter from one side and come out from the other side with it's properly partitioned. So that's the ideal for a place where you're holding COVID-19 patients, whether pregnant or otherwise. So speaking to the our first patient, she arrived on the 25th of April, 38 weeks pregnant, with a previous cesarean section. She was referred from a private hospital and she was asymptomatic. She had absolutely no COVID-19 symptoms. We had to have a meeting scheduled for the same day she came in, on Saturday, of all the stakeholders. Everybody stated their consumable needs, which were like long lists, about 10-page lists of equipment and consumables, but eventually we managed to whittle them down and found that some people had been doubling, asking for the same thing. So we brought it down. We had the pre-op blood tests and registration. Fetal monitoring issues were also considered. We had to have a simulation the next day on Sunday. We walked towards theater, how to put on the PPE. Can you hear me? I think my internet connection went a bit unstable. Can you hear me?
No, we can still hear you.
Yeah.
Great. So the simulation was done the next day. They walked through. There was demonstration of PPE donning and doffing. And then we have this theater that was dedicated to COVID-19 patients. We renovated and rearranged it. And the main issues were the contact between the isolation ward, where the patients are put in before they come out to go to theater, and the outside world, as I put it, that is the rest of the after the woman, for example, the pediatricians. So WhatsApp came in really useful. We consented the patient with WhatsApp after speaking to her and giving the information that was necessary, and she was delivered on the 27th of April successfully after we did all that was needed to be done. So generally, I experienced thus far 9 patients, all presented in the 3rd trimester. 1 booked, 8 unbooked. By that I mean 1 was registered with us and 8 were previously unregistered. We were seen as the COVID-19 delivery center at the time in Lagos State. Then there were 7 asymptomatic patients at the time of presentation. The 5th one was the most symptomatic woman, and I'll speak about her in the next couple of slides. We only had 1 vaginal delivery for a woman that had an intrauterine fetal death. And she had had that death before she came into the hospital. So we delivered her vaginally. For the 5th patient, she was a 33-year-old Asian woman, 35 weeks pregnant. She had no contact or travel history. She was a known asthmatic, and she had been treated with oxygen and salbutamol and antibiotics before coming to us. Her chest X-ray showed suspected COVID-19, and then that was when, and she also suspected acute pulmonary edema, and that was when she was tested and she was found to be positive for COVID on RT-PCR and referred to us in Luth. She had had 1 previous cesarean section, so we knew that we were most likely going to deliver her by cesarean section. When she came in, she was quite poor, she was oxygen dependent, but it got even worse by the 2nd day, where her respiratory rate was about 50 cycles per minute. She was in clear respiratory failure, needing up to 15 liters of oxygen per minute. And we had to quickly do an emergency cesarean section, even though she was just still 35 weeks, in order to be able to resuscitate her properly. She seemed stable immediately after the cesarean and then deteriorated on the 4th day. She was very oxygen dependent still. There was no ICU space in order to give her, ventilate her. And we couldn't lay her prone either. She wasn't comfortable lying prone. So it was sitting up. This woman sat up for about 10 days on oxygen in order to get the oxygen to her. That was the most comfortable she was with the oxygen. She was barely sleeping. On the 10th day, she seemed stable. So we weaned her off oxygen only for her to collapse immediately. She became unconscious. So we put her back on oxygen, and then the hematology unit, because of the multidisciplinary team we had, hematology was also on the WhatsApp group, and one professor of hematology of ours thought, this woman, let's check her hemoglobin. He found a high level of methoglobinemia, and he decided, let's try and exchange blood transfusion. It was after she had this exchange blood transfusion that she became less oxygen dependent, and we finally weaned her off oxygen, and she went home 22 days after admission. She had been negative for COVID from day 11, but she was still very sick until that EBT was done. So the lessons learned, and the last words I'm going to say is that the PAC system is very useful, and for the consumables and drugs needed. It's important to ensure the theater is decontaminated and cleaned. You have to walk through your patient transfer to theater, surgery, or labor, and also do appropriate post-op management and nursing of the neonate and monitoring before you have your first patient. All these things have to be thought through and walked through in your mind and as a proper drill. Babies were all negative. They were roomed in with the mother and breastfed, although whenever she wasn't carrying them, they were put separate from her. But the mother was still allowed to carry the baby and breastfeed the baby. Multidisciplinary care is crucial. That's what saved that number 5 case, and it's important to ask for help from all the people around. The situation is improving, the fear is less, and I need to emphasize again about the fact that the T-Vex suits and co, even though they look nice on on pictures or look impressive, let me not say nice, in pictures, are totally unnecessary. They're a waste of a lot of resources. And I also want to acknowledge maternal and newborn care team who were excellent. The nurses, the doctors, the engineering staff, everybody really contributed to making things work well for us for the safe delivery of these COVID-19 patients. These are my references, and I thank you very much for listening.
Thank you very much, Professor Afolabi. It's brilliant to hear this, and I think you will have a lot of questions at the end. So please do stay on, and people can put in their questions in the question and answer box that we will be able to answer from there. I'm just quickly going to run over the IPC site, and we've already covered quite a lot with Professor Afolabi's presentation. So I'm not going to take up too much of your time, because we still want to give some time to Vanessa Carter, who's going to talk to us about patient safety, because tomorrow is World Patient Safety Day, and there's going to be a global 2-day conference happening as well online, so please check it out. So I'm not going to take too much of your time, so I'm just going to quickly share my screen so we can just quickly go through the basic IPC situations, and I think all of you know most of them as well, so I'm not going to take up too much of our time to discuss that. What we just want to say is that we want to just look at the prevention and control methods, the significance in the maternity unit, which Professor Afolabi actually clearly explained to us quite clearly. We've also got the requirements that we spoke about in context of the COVID, the antenatal, the labor, and the postnatal care that we want to look at. And we just want to see that, as Professor Afolabi also said, is globally, most of the cases have evidence of human-to-human transmission through droplet and contact. And to date, we don't really have any real studies showing that there's any transmission through amniotic fluid or cord blood. And as Professor also said, that none of the babies were positive. And also at present, there's no recorded cases of vaginal secretions and breast milk being tested positive for COVID-19. So we want to ensure that the mothers still, if it's possible, can continue breastfeeding. However, since it's been detected in some stools, it could pose a risk to the neonate during birth if they're in the physical proximity of the perinatal region. And then also just to make sure that we carry on with our IPC practices to reduce transmission by standard precautions, and then add on the contact and droplet precautions for mothers and the neonates. And we also, like Professor Afolabi said, we need to have a designated area for if we do have a suspected or confirmed cases, that we can treat them there or care for them there, including your fully equipped labor and delivery room. Also make sure that the healthcare workers assess their risk for exposure, and then to use, as Professor Afolabi said, appropriate PPE, not just put on because we feel safe and actually increases our risk. And then also very important is our hand hygiene performance that we need to continue using, either by washing our hands or using alcohol-based hand rub, and even before and after using our gloves, to understand when and how to use that. So we just want to make sure that we also explain in the community that when people are pregnant, they need to understand how they can prevent themselves, protect themselves from COVID. And like we've said before, Hand washing, very important, the physical distancing, and before we spoke about social distancing, but to make sure that there's that space between us and the people next to us. And then even if we do cough, to use our bent elbow or into a tissue and then dispose of that tissue and perform hand hygiene, and then also to try and avoid touching our eyes, nose, and mouth. And we also want to make sure that people understand that women have the right for high quality during antenatal, intrapartum. The newborn need to have proper care postnatal, and then also to look at the mental health. And we've already spoke about that. So in the antenatal care, we want to make sure that if they are at risk, if there's no proper ventilation, or if they've got no spacing between them when they visit the clinic, so we want to make sure that the clinics understand how to screen and triage also before the patients enter into the clinic, to make sure that we also, if we can, number the clinic bookings, but make sure that we've got more dates available for them, and ensure that there's space between the seats or the space where they wait before they are getting seen by the nurse or the doctor. Also to make sure if we do screen them, that we know that we've got a dedicated space. If we do have a positive patient, that they can still be seen, and we take the necessary precautions for that. And if the mother hasn't got a mask, to give them a medical mask, and she should be seen, if she's positive, separate from the others in the isolation room. We need to continue our care and also consider the labor, during labor, and if she do have a cesarean section, how to look after the patient. And as Afolabi said, that a lot of them in the third trimester getting sick, and if they do, they're getting quite sick and they need extra oxygen. So we just need to make sure that we all work as a team, as Professor Afolabi said. It's really very important that the whole team, multidisciplinary team, take hands and we all work together. So if we do have a normal delivery, or even in the theatre, we want to limit the access for people coming in and out. People need to wear the appropriate PPE, and ensure that we also have all the equipment, that we don't need to go in and out. Make sure we alert all the necessary people that need to be on assistance, like the pediatricians or specialists, or if they need to go for an emergency cesarean and we need to get anesthesia, so that all the people are on call. Make sure we do continue fetal monitoring and make sure that there's timely delivery and intervention if there's fetal distress. In the second stage, to make sure that we wear the appropriate PPE as well, like Professor showed there as well, your surgical mask, your gown, and your gloves, and then goggles to face. And then if there's close to the patient when they are actually doing the delivery, to ensure that they then have the N95 and the visor to protect them further. The newborns without complications can also be kept with the mothers. We want to allow them to still hold and get that physical contact with the babies, but just to also help them to ensure that they wear their mask and also perform hand hygiene before and after touching the baby. Proper cleaning of our equipment, and then also our waste management. And we're not going to go into too much detail about waste management, but waste management, even if it's a positive patient, will be treated as if it's normal infectious waste, like we normally would have done, label it, store it, and manage it like we've done in the past with our infectious waste, and then also your medical waste from there. In the neonatal isolation wards, we want to also ensure that we've limited the access there, perform hand hygiene, ensure that we've only got your dedicated staff entering there, and if the mothers come in on the parents, to ensure to educate them how to handle the baby, perform hand hygiene, how to protect themselves and the baby. We spoke about the waste, and then also just to make sure we keep the doors closed at all times. That's for safety, but also to prevent too many people to come in and out. And then the doffing area to be designated outside the isolation units, and to place all your infectious waste inside before it's being moved to the waste holding area. In postnatal care, we just want to talk, and as Professor Afolabi said, we want to encourage breastfeeding for the mother to keep on. If she's too sick, we can help her to express breast milk, and then the baby can be fed the breast milk through the cup. Or if there's other alternatives that need to be done, we can use infant formula, but try and re-lactation for the mother if possible, if they want to continue with that when they go home. So there's a lot of posters available on WHO website as well to ensure that we perform hand hygiene, wear your medical mask, routine cleaning and disinfecting of the area around you, and then also about expressing breast milk if necessary, and then also to help the mother to understand. And part of this is also be about kangaroo care, and we spoke about this, and there's a lot of information on the websites, and you can go to WHO, CDC, Africa CDC, ICANN, and even in some, I think in most of the countries do have this. We want to ensure that we've got the kangaroo care, skin to skin, just to make sure that we also protect ourselves, wash the clothes and our arms and the areas around us, make sure that we put on new, fresh clothes when we touch the baby and after went out and come back in, and also then to make sure that we protect ourselves and our family members and that coming in if they are allowed. Now with the COVID-19, we know that there's a lot of restrictions about visitors or even family members going into the areas. So, but if we do allow the fathers, we know there's a special routine that we follow with them to be tested and before they are allowed in. But I think part of that is also when we talk about the mental health, to make sure that we also look after them for that. Because a lot of mothers, if it's a young mother or if there's some complications, they definitely need that assistance from their spouse or from their partners to come and help them. Linen management, as before, we've touched on this as well. I'm not going to go into too much detail. We handle our soiled linen as gently as possible to prevent contamination. If it's just normal body fluids, we roll them up, we discard the excess feces or the excess organic material, then use it wet, put it in a bag, label it, and then send to the area where it's been washed if they've got a laundry or if it's been washed by hand, to make sure people understand how to protect themselves as well. And then also to make sure that if you do wash them at least at a 60 to 90 degrees. If you don't have a wash machine, make sure that you use your detergent and you treat the soiled linen before you wash them properly. And if you need to disinfect them, you can soak them. We don't really like that, but if you want to, you can. To just make sure that you're feeling you're safe. If you expose them to heat as well, you can put them in the sun if you're in an area where there's a lot of sun. If you don't have a tumble dryer, and then as well to iron if it's not, if it's possible, to expose to that extra heat to make sure you've got your clean linen. But I just want to mention on the linen as well, we just need to remember COVID-19 patients, the same as your normal infectious patients that would be in isolation, so you would treat the linen exactly the same way. With environmental cleaning in the maternity, also you need to have your cleaning schedule as normally. You will increase your frequency as well, and also make sure that you, after each delivery, you will clean and disinfect the area, especially high touch surfaces, according to IPC standards. And then terminal cleaning will be done at least once a day from the whole side, the delivery room or even the theatre. And all your medical equipment, if it doesn't need sterilization, and those are like the blood pressure cuffs or the fetal Dopplers, the ultrasound machines, remember we need to clean them properly, and then you can wipe them down with either 0.1% chlorine or alcohol, or even if you want to use hydroperoxide, 0.5%. And then just on waste management as well, when we want to just emphasize the cradle to grave concept, from where we are generating to where we are disposing of it. Make sure you do have your sharps container close by, your bins labeled according to segregation, your red for your medical waste, and then your yellow for the infectious waste, or depending on your facility, what is the color coding that you are using, and then you will dispose of that and ensure hand hygiene is also performed afterwards. The sharp boxes, and then also follow your company's waste management process. Make sure that also your housekeepers and the cleaners that are wearing the appropriate PPE, and that they would be taking also standard and transmission-based precautions into consideration when they are cleaning and when they dispose or remove the waste and the linen from one area to another. And then just some references, and I want to just thank WHO and ICANN's guidelines and all the other references that we've put on there. And there will be time for questions at the end. So I just want to thank you for that. And then I think it's my big privilege to also welcome Vanessa Carter, and she's going to talk to us about patient safety. And Vanessa will be able to share her screen as well. And Vanessa is going to explain a little bit to us about, from a patient side, what happened, and she can take it from there. Over to you, Vanessa. Thank you.
Okay, thank you very much for everybody for having me. Okay, I just want to see if this is working. Sorry. Okay. Okay, can everybody see my screen?
Yes.
Okay, great. Sorry, I'm just going to take this out of the way over here. Okay. So thank you so much for everybody for having me. I present from a patient perspective, having been a patient that had a very long battle with MRSA. So through this presentation, and because it's Patient Safety Day tomorrow, I'm going to share my story about it, and then hopefully it could help you in your own work as healthcare professionals, or whatever else you're doing in healthcare at the moment. Sorry, I'm just trying to change slides. Okay, there we go. So just a bit of a background on me. I'm a patient activist for antimicrobial resistance. I'm a Stanford University Medicine X e-patient scholar for the 2017 program. I'm the founder of Healthcare Communications and Social Media South Africa, which is an acronym that I use, HCSM SA. So this is because my background professionally was in advertising and marketing for 18 years before I became a patient advocate. And then I'm also advocacy, disease, civil society champion. So if you'd like to learn more about me, this is my website at the bottom, which is vanessacarter.co.za. So the main take-home question that I want you to think about throughout this presentation is, do you think patients matter to infection prevention and control? I'm not going to answer that. I'm going to present it, and then, at the end, I want you to really think about it and think how patients can become part of the team, in terms of RPC. So let me start with my story. This was the last photo that I took when I was 25 years old, before I had a massive car accident. This was in 2004. I was a passenger in the car, and this was actually a City Golf. It was unrecognizable. I was taken through to the Johannesburg Charlotte Mrsa Academic Hospital. I was on ventilators. I was on life support. I was in high care. I had a 30% chance of survival. So in the room that I was in, it was very, I would only let one person in at a time. It was infection control was extremely important for my survival. But I managed to get through without any infections. Luckily, no meningitis, even though I had a massive head injury, no sepsis. So I was a bit of a walking miracle. So my injuries at the time were, I had a massive head injury and facial fractures. I had a broken nose, broken jaw, smashed right maxillary sinus, orbital blowout, I lost the right eye, and I had severe facial lacerations that basically went right through the face, down the cheek. I had a major abdominal injury. I'm not even going to try and attempt to read some of these medical words that were written in my medical record at the time, but I did need emergency laparotomies because of the internal bleeding. I was resuscitated at the time with a defibrillator on the side of the road, and this eventually resulted 8 years later again in an adhesive bowel obstruction, which nearly killed me for a second time. I had a fractured pelvis. I had a neck injury, a major neck injury between the C1 and the C2, and a back injury at the L5 area. So it was a very, very long recovery for me. So this was my first year of recovery. The bottom photo I kind of threw in because it was one of my last photos as well when I was 25. But the top two are, me trying to get past that first year of, number one, no longer being able to recognize myself because of the facial damage. learning to drive again, learning to walk again, extreme headaches and swelling, a 6-year medical legal trial which followed that because I was a passenger in a car. As I said, learned to accept my face again, learned to work around one eye, and figured out how to fund my surgeries. So, you know, I got over the pain. The first year was really the pain that I had to get over, and figuring out what was next. The longest part of my surgeries would end up being my facial reconstruction, which stretched over a period of about 10 years. Mainly because it needed different types of super specialists, and it needed to be performed in different stages. So this was the first CT scan that they did in 2004. At the time of the Joburg Gen, they managed to do some facial reconstruction and ocular implant or silicone implant. And yeah, so this was basically what I had to work with. You can see that there was a very big gap, you know, in the bone, which was what we needed to start repairing. So 6 years, during the 6 years after my accident, I had several prosthetics implanted. The fourth prosthetic was an alloplastic implant, which also applied 3D printing technology at the time, which meant that the implant itself was better than something that it was more custom made for what I needed. So on the left hand side, this is just sort of an illustration. This isn't actually what they did to me, but the gray area is sort of shows this. Alloplastic is a gray type of plastic that they use to bridge the gaps in the bones, which was basically implanted by a maxillofacial surgeon in 2010, just underneath the eye. So a few weeks later, we had an ectropion surgery done by a plastic surgeon because the incisions started to adhere to the alloplastic. And a few weeks after that, I developed an infection. So I always explain this as, yeah, I went to the shops one day, I was shopping, I got into my car, I pulled down the rear view mirror and I felt this moisture and I didn't know what was going on. And I saw this coming out of my face and I panicked. And I phoned my plastic surgeon's office and they said, look, come in, you need an emergency surgery, you've got an infection. And anyway, I went into their offices, and it sort of led to a debridement and a reconstructive surgery, and then the infection would come back again. And, you know, then I'd go for another debridement and reconstructive surgery, and then would come back again. It was just recurring and recurring and recurring, and this would go on for about 11 months. So, you know, even though I was under the care of the plastic surgeon, I was also under the care of different types of surgeons. So, you know, so I would, for example, go to the plastic surgeon if the infection came back, you know, then the maxillofacial, I would say, well, go see the maxillofacial surgeon. And then I would get different opinions and prescribed the same type of antibiotic each time I saw each different physician. You know, so this was a major problem. It was a communication problem, and it was you know, fragmented communication, if you want to put it that way. So this was one of the emergency surgeries and debridements, as I said, that we kept doing for almost a year to repair the soft tissue. You can see that the stitches at the bottom was the you know, the amount of soft tissue that was eaten under the eyelid by the infection that kept coming back. So eventually, after 11 months, I called this the point of no return, where my plastic surgeon, you know, eventually stepped forward and he said to me, you know, he was working, and I was supposed to go for an ENT surgery that day to do sinus drainage to see if we could try to get rid of some of the infection in the sinuses. And he said to me, you know what, I'm going to be in the theatre next door. I'm going to come inside there. And can you hear me? Yeah?
Yes.
Okay, sorry. And he said, if I see the infection is still on that prosthetic, I'm going to take it out. Even though you haven't asked me to, we have to take it out. And at that point in time, I didn't understand why he was so adamant about taking it out, because other doctors were telling me I could leave it in, or I could, you know. And when I woke up from surgery, I remember at the end of my hospital bed, the ENT surgeon sat, and this is what I looked like. This was now the damage. And he looked very despondent, and he said to me, I don't know if we can fix this, but, the plastic surgeon took it out because we didn't have a choice. And but we're going to work together. We're going to try and sort this out. And that rang alarm bells for me. So, because I couldn't understand why this plastic surgeon had taken the chance to take this infected prosthetic out. So I phoned the pathologist offices, and they sent me a test back that said I had MRSA. And this was the first time that I'd ever heard of MRSA, antibiotic resistance. So as any patient would normally do, which we get told not to do, was I turned to Dr. Google to learn what MRSA was. And it was stressful because I didn't know that getting prescribed so different, or the same antibiotic over and over again, was actually aggravating it. And it made sense then why my plastic surgeon had done that for me, had removed this infected prosthetic that was riddled with MRSA, because it could have moved to my other prosthetics and it could have gone into my blood and it could have killed me. So through that, I also started to understand that I couldn't make any more mistakes. I needed to make informed decisions. My doctors knew what they were doing, but they weren't communicating. They weren't treating me, holistically. So I started searching for doctors on Google who were working on cases like mine. And, one day I was very lucky because there was a doctor at Brigham and Women's Hospital that was working in the face transplant team, whose secretary emailed me back and said, Dr. Edward Caddison, he's a craniofacial surgeon working in the face transplant team. You've emailed him. I actually ended up finding his articles, his research articles about face transplants. That's how I found him. He's willing to give you a 30-minute Skype call. Are you okay with that? And this was back in about 2011. So, when we start talking about telemedicine nowadays, this is basically what he did from the USA to South Africa. And he said, over 30 minutes, you need to not put any more foreign objects in there. You need to do a zygomatic osteotomy. You need to do basic plastic touch-up surgery after that. As few surgeries as possible, try and avoid the infection. Find somebody who mimics my advice. And so I did. And I found a professor from Wits University working at Sunninghill Hospital. This was after visiting quite a few different doctors. And he, to the last point, gave the exact advice that Dr. Caddison had given. And so we went ahead with the surgery. And this is what my face looks like today. So a zygomatic osteotomy is when they cut the zygoma on the arch and they rotate the bone forward to get the volume underneath the orbital floor. So what he basically did was, you can see all the plates holding the bones together. So, I've made a note on the right-hand side saying I'm an infection prevention nightmare with multiple prosthetics. So, COVID for me is the ongoing infection prevention control has been the story of my life for many years. Don't touch your face, because if I touch my face, I risk getting infection in all of these prosthetics. So it was very important for me to learn exactly how I had to play a role. And I'll go back to the original question that I asked. My role as a patient in managing my infection in my daily life, basically. So we did do the zygomatic osteotomy. I did get an infection, which we feared was a bone infection, but it turned out it was actually a mild infection and an allergy. We thought it was an allergy to Chloromix, which is a topical antibiotic, which I had developed, using on the surgical sites all the time. I'd eventually developed this allergy. So Professor started to rotate me on antibiotics from then for about 3 months. This was 2 months after we started rotating. And he asked me to report back in every week and follow strict IPC, at home. And, so this wasn't just a case of, clean your counter because patients are in hospital, right? But they go home after surgery, and especially in countries like ours where they're not in hospital for very long, especially in the public health system, and they need to go home and they need to understand things like, sanitizing the surfaces where they prepare bandages, sanitizing, you know, in my case, I had an iPad that I was wearing all the time, that I need a very sterile surface to work on. So he taught me that. He also taught me about antibiotic resistance. You know, something like he sat me down the one day for 30 minutes and he said, Vanessa, if the pharmaceutical packaging says to you take it after meals, ignore it. You need to take it at equal intervals. If I say to you take it on my prescription, if I say to you take it at 5 o'clock in the afternoon and 5 o'clock in the morning, you set your alarm clock for 5 in the morning and you do not allow a 20-minute window from 5 a.m. in the morning. Otherwise, what is going to happen is you're giving the bacteria a chance to mutate. So I understood it. He empowered me. And in that sense, I could start participating to look after my own infection at home and in hospital, you know, better than what I could when I wasn't empowered. So anyway, so eventually I got over the infection and the allergy from all the rotating and, you know, strict IPC at home. And then we did the once everything cleared, we did the final touch-up surgeries, which doesn't look too good here, I know. And the allergy cleared as well, as I said, which was a rotation flap in 2013. And 6 months later, because soft tissue finally settles, this was the result. And I'll tell my story one day, but there's not enough time right now. So, so this was for me 3 lessons learned as a patient for extensive infection prevention and control of MRSA. And I think eventually it ended up being about 3 years of dealing with, you know, very, very extensive MRSA. So, so number 1, educate patients. Educate patients about their role in there was a sentence of care from everybody, nurses, doctors, everybody. It wasn't enough information for me to be a role player in my care. So any infection is a team, and I've heard a couple of presentations now. You spoke about hospital is also extremely important in the team. You know, because this way brings a team.
Sorry, Vanessa, we've lost you there. Can you just repeat that? Vanessa, can you still hear us?
Hello?
Hi, Vanessa, can you still hear us?
Hello, can you hear me? Yeah.
You're back on now.
I don't know where I ended off there. Sorry.
No, you dropped off. It's just on the last one. If you can just repeat that one. Thank you.
Okay, no problem. Let's see if I can get there again. I think it's just a bad connection.
Yeah, I see the internet is...
Hello?
Yes, you can carry on. We can hear you now.
It's bad.
Maybe if you just want to just, I think this, you've only got a few more slides. If you can maybe
just can.
I'm sorry, we're losing you, Vanessa. Do you want me to try and share from my side? Vanessa, sorry, we are missing you. So I think she dropped off. But I think, you know, when she comes back on, we can just maybe discuss it again. But I think I want to hand over to Dr. Yewande, we want to thank everybody that was on the call, and then maybe we can start taking questions from there. And when she comes back on, she can just maybe share the last one or two. But the presentations will be available. Over to you, Wande.
Thank you. Fantastic. Thank you very much, everyone, for being on the call. And thank you very much to our panelists. On my panel today, I have experts from ICANN, Prof. Shade and Anna on the call. I also have Professor Falabi, who gave a fantastic presentation earlier. I have my colleague from Africa CDC also on the call. I have experts from US CDC, Public Health England, and Resolve to Save Lives. So we will just start talking a bit about the questions that you have put in the Q&A chat. I encourage you to put all of your questions and comments to our panelists on the Q&A chat, just to also bring us back to why we're talking a bit about patient safety. Tomorrow is the World Patient Safety Day, and for us as Africa CDC, based on the work that we have been doing around COVID, we're particularly keen and committed to ensuring health workers' safety and also prioritizing patient safety. So on that note, I will start with some of the questions. Some of them are really directed at Professor Afolabi. So I will start with some of them. Just very quickly, I think some of the questions were that looking at healthcare worker infection in maternity wards, is this like any other aerosol generating procedures? And do you recommend midwives to don N95s and put on goggles during the second stage of labor? I know that Anna's taking a go at that, but if you would also, Prof. Afolabi, talk a bit about that.
So you're asking about if during labor, if midwives should don N95 masks?
Yes, so I think you can speak a bit about what PPE we recommend to midwives during labor, and I would also let colleagues from ICANN speak a bit about that. Thank you.
Okay, so what from our point of view, we tend to recommend face masks, but also surgical face masks with shields, just because of the fact that some of the droplets could enter the eyes when the woman is screaming or pushing severely. But in terms of aerosols, as long as the woman is not being intubated or suctioned, I may be wrong, but we don't really anticipate that, so we don't recommend N95 masks. But if it is a COVID-19 positive patient that you're dealing with, then I suppose it's not too much to be safe in terms of using the N95 mask. But once you have your shield, I feel, and surgical face mask, I think you're okay.
Thank you, Anna and Prof. Shade, did you want to add anything to that, or should I move to the next question?
I think you can move to the next question. The shield with the face mask is fine.
Okay, so the next question I will be throwing to my colleague from Public Health England, Emilio. For patients with planned deliveries, are patients trying to understand what this question really says. Are patients?
Okay, I think I get it. Whether they're receiving COVID-19 tests prior to being admitted to the facility.
Yes, okay, so if you would like to speak a bit about that.
So for the patients we've had thus far, they had all been tested before they were referred to us. So, but in my institution as it is, no, we don't test before admission. It's only when they come and we suspect it that we test. Because of the tests are very expensive and it's not that common in pregnancy.
Okay, fantastic. Thank you very much for that. I'm just looking through some of the questions because some of our participants cannot see the answers you've put. I will read some of them that you might have given some answers to. to provide some sort of context to our conversation. And just before we wrap up this session, we will go back to Ms. Carter's presentation to give her a chance to wrap it up. So I think the next question I will throw at you is, given the risk of neonatal COVID-19 infection is 0, in addition to the standard precautions used by the mothers, are there any other IPC measures we should consider for the baby to ensure 0 risk? So I will make this sort of an interactive one. Prof Afolabi, for you to go on and say something about that. I see Anna has also given a comment, and I'll give her the floor to also chip in on that. Over to you, Prof Afolabi.
Thank you. So for the neonates, what we have found so far in our little experience is that once we have the mother sanitizing before and after she picks up baby and masking when she's breastfeeding, we haven't had any problems. And the babies have not, contacted COVID-19 even after we've delivered them and they've gone home. So so what I would advocate based on that experience is just sanitize and mask to breastfeed. Thank you.
Okay, thank you. Anna, Prof. Shade, if you wanted to chip on that from an ICANN perspective.
Sorry. No, I think that really works. I believe in keeping it simple and effective. And I think that's really the most important thing, because COVID-19 has not been found in breast milk. So its transmission in breast milk is not, there's no evidence that it is. So really, if the baby is going to catch it, it will be from the mother's, if the mother is positive, breathing on him. So once the mother is masked and the baby is feeding, I think that's fine. And the environment is kept clean so that the possibilities of transmitting to the baby from an unclean environment is also taken care of, and the mother is sanitizing, then we should have no problem.
Can I just say one thing here?
Yes, please, Karen.
I think this fits in very, very well with Ms. Carter's phenomenal presentation in terms of patient education and empowerment. And I often worry about this, that mothers are quite stressed when they first have a baby. So it really would be important in COVID-19 mothers to take the time and not panic, but educate them about ongoing sanitation and hygiene, and make sure they understand that the baby is safe so long as they do the simple measures that Prof has gone through, and walk them through how to do it very, very carefully while still in hospital, so that they sense they're in control of the infection prevention.
Okay, fantastic. So I think, thank you so much, Karen, for sharing additional insights to that. I think I will take one last question, then I will give Ms. Carter the floor to just wrap up our presentations. We definitely welcome more questions around patient safety and patient protection directed at Ms. Carter. So I think this question may not really be around surgery, but I think it's something that we have all been concerned about. This person says that I work as an IPC project implementer, and how best can you on-site chlorine generators to be used as IPC intervention package. So if I'm correct, I would like to assume that this is what the person is talking about, the chlorine spray generators. So I think that's something that as a group and as technical experts, we've all been worried about. We've tried to review evidence and provide guidance. So I will let some of my panelists just speak a bit about that, just to provide clarity to our participants on the call. So Professor Shade, I will just throw this at you because I know that this is something you have been particularly passionate about, and I will let other colleagues also speak about their experience from different parts of the world and provide guidance. Over to you.
Okay. The issue of chlorine generators, let me clarify. We're talking of, fogging with chlorine, as well as these little chlorine packs that people are sticking around their necks. Are those what we're talking about, or the fogging?
So Thomas, if you want to clarify, but my assumption is that is what this person speaks about. So Thomas, feel free to put a comment if we're wrong, but I believe that that's what the person is on about.
About fogging.
Yes, Prof, about fogging.
Oh, okay. Yeah. We in the IPC community are really concerned about fogging, because what people are doing is just spraying chlorine in the air. And I just think we need to step back and think again about how COVID-19 is transmitted. It is carried around by people. It will come out of the respiratory tract. And so if you fog everywhere and someone has COVID-19 and you're close enough to him and it passes to you, that fogging is of no use. That's one. Two, if you're fogging in the air, the dilution, what are you fogging? What are you, how do you, the concentration that you would need and the amount of time it would stay there, how it wouldn't solve the problem. That's two. The third thing is, most of the time when people bring out from their nose or their mouth, it's going to drop on surfaces. It is a lot more efficient to clean the surface and then put disinfectant and wipe it clean and then cover with disinfectant. That would get more, would solve, should I say, that would break the chain of transmission much more efficiently than anything fogged. Then the final one is when you just fog and spray disinfectant. We also know that organic material deactivates disinfectants. So it's just falling on surfaces. The organism could be very well protected by some organic material. So you're not really reaching it. So it gives a false sense of security. So it's a lot more effective to wear your mask, to wash your hands, because those are the ways it is transmitted to the face, and also to clean your environment and then keep the distance. So if you can do all those, there is really and absolutely no reason for fogging. And finally, we're fogging and putting chemicals in the air. We also know that people are allergic to this. And in a study that was done, I think Professor Mrsa did some in Sierra Leone, and there are others, to show an increased level of allergic reactions and harm for people who are doing, who have been in the vicinity of chlorine in the air. So this long-winded story is that fogging is not effective and really should be discouraged. Thank you.
Yeah, this is Elizabeth Bancroft, and I want to, from CDC, I want to second everything that Prof just said. And we are also very concerned about fogging, how it might affect the respiratory system and the eyes, and the irritation that it will give to the respiratory system and the eyes of the people who are caught in the fogging. So for all the reasons of it being less effective than just doing good cleaning and disinfection, and for the fact that it can actively cause harm for the people who are doing the fogging or the people who are in the immediate vicinity of the fogging, we strongly discourage the practice of it. Over.
Fantastic. I think we have all just agreed on the same thing. As an institution, we also discourage the use of fogging. It's dangerous to health and also to the environment. But thank you so much for that question. We just keeps coming up during our sessions. Ms. Carter, if you would like to share your screen and go over your final slides, then we can take some other comments and questions for you.
Okay, sure. Thank you so much, Wanda. I just hope that this works this time. Okay, let's try. Okay, so I think I got through this slide. It was educate, manage, empower, manage the infection as a team in and out of hospital. Patients are part of the management team from IPC to antibiotic stewardship. Teach them IPC, teach them how to adhere to antibiotics, tell them why. So the why is always important. Empower patients to track their infection and send feedback to their healthcare providers, healthcare professionals. This is what made the biggest difference to me, having Professor Reinecker give me a lifeline, even though it was email, you know, to say to him each week, how am I doing? Because as patients, we're very scared to report on our progress because we don't want to take up the doctor's time. So this is an important thing to try and resolve through the healthcare system, is to understand how patients can give feedback all the time. And I just want to also emphasize that I've been a patient both capacitated and incapacitated. I've been on ventilators at certain times. I've been in ICU, I've been in high care, but I've also been able to, in those circumstances, I had to rely on the medical team around me, but as I recovered, I was a team player. And so that's what I'm basically talking to you about today, is understanding when a patient is a team player, how they can play a role. So I had a good relationship with my doctors. This was part of my team, my plastic surgeon, my ocularist, my ENT surgeon, professor, the maxillofacial professor, and my ophthalmologist. So I just want to quickly give you an example of why teamwork matters to infection care. So one of the questions I got asked while trying to defeat MRSA was, are you keeping that artificial eye sterile because it is another foreign body, you should remove it? When I was in hospital, the nurses didn't think about that. My plastic surgeon didn't think about that. My maxillofacial surgeon didn't think about that. It was my oculist and my ophthalmologist, because they were trained to think about that. That was an extra artificial foreign body in my face. And I hadn't taken it out until they told me that it was necessary to do so. You know, my body could only fight the infection to a certain point. I had to try to get rid of as much foreign objects as possible. So the last of my infection, and I'll bring up the ophthalmologist again, as it started disappearing, I showed you that 2-month period where we rotated antibiotics, was blepharitis. Now this is terrible to try to get rid of. It was resistant blepharitis on my eyelids, you know, on my eyelashes, which really needed some extensive care from our side before it turned into something worse. So again, this came from the ophthalmologist, who wasn't visiting me in the hospital. He was caring for me in between hospital visits. So it was important that he was included in the management of my infection, my MRSA as a whole. So I've heard a lot about WhatsApp, which I think is great, because you know, being an e-patient scholar, I believe in technology. I used Google myself, and you know, so we have to ask ourselves, if this is the future, how are we going to design meaningful tools? And so one, which I brought up now, is to track adherence to antibiotics. 2, to provide reliable information to patients about IPC and antimicrobial resistance. These might be lifelines to patients, because we all know that Dr. Google has got Google and the rest of the internet has got a problem with fake news, misinformation. So it really should be up to the health system and others to provide these tools to patients, because I know as well that the time that Professor Reinecker took to explain these things to me is not always practical to everybody else. So, for example, is there a way to design a website where everybody in a particular hospital could say to a patient, if you go visit this page, here is an app, this is going to help you understand exactly what you need to do. I think that needs to be thought about. track infection progress daily, as I said, and capture data on a medical record. You know, so these types of ideas are endless. So to end, put power into the patient's hands too, because we matter. So this is a quote from me. You're welcome to use it anytime. It's, as a patient, I had to take care of my infection when my nurses or doctors weren't around. That was equal to about 90% of my time fighting MRSA on my own. As long as I was powerless to fight my infection, it always won. So thank you very much for having me, and I'm sorry about the technical problems, and yeah, I look forward to any questions that you have.
Fantastic, thank you so much. I think we have a couple of minutes left. Just to say that we have seen comments where, again, this comment just really emphasizes the fact that we need to put more information, we need to provide patients with more information to re-emphasize the need for patient safety. And it's great that, Vanessa, you shared your story. I think that comment had come for you. I think just to re-emphasize that we ask everyone, healthcare workers, patients on the call, and the general public to join again the global IPC community tomorrow as we mark the World Patient Safety Day. Feel free to check on all of our various social media pages, Africa CDC, WHO, US CDC, Public Health England, ICANN, Resolve to Save Lives. We will have enough materials for you to use. If you're not very familiar with this, just feel free to check our various websites for further information. So I think on this note, I know that Anna has to work everyone through the QR code for your certificate. I would just like to thank all of my panelists and speakers for today. I think it's been a fantastic session. I know that there are a few comments which are not necessarily related to this, but feel free to throw in your questions on the community of practice via Telegram. And thank you so much to our participants joining in from Facebook Live. Over to you, Anna, to take us through the final session.
Thank you very much, Wande. Yes, it was very informative, and I think it's great that we could talk about patient safety as well. I think that's something that we as healthcare workers really need to think about. Every time we get in contact with a patient, we tend to talk over the patient and not with the patient. Like Karen also said, I think it's important that we really need to talk with the patient and ensure that they understand clearly, because it is not easy for them to be in a hospital and going through either delivery or illness or infection. I think it's very important. So then over to the app as well, the social, and I know that some of you said you couldn't download the app or couldn't scan the code. Here is the end code as well, that when you scan the start code in the beginning, and if you scan the end code at the end, you will be able to get your attestation on your app. It will immediately tell you that you've actually scanned and you've attended this, and then you can press on your app the left-hand button, and it will show you all the attestations that you had. I know a lot of people want to know if they can't get certifications for this. It is just very difficult for us to be able to give everybody that's on the call and go through the whole list to see who stayed on and who dropped off and all of that. So it's very difficult at the moment for us. So the QR code works quite well. So I'm going to just share with you again the start code, so you can scan the start code, and then you can also scan the end code. And this will be available, and we've also put it on the Telegram community of practice, so you will be able to find it there as well to screen afterwards the start and the end code, and it will give you the attestation. And also some of the presentations are already on the app as well, but it will also be on the Africa CDC website. This was live streamed as well, and it will also be on the ICANN website available. And if you do need anything else, you can contact us by email as well, and we'll try and accommodate you with that. Thank you very much. And then next week we'll have a rest, and then we'll start the following week with series 4. And if there's any topics that you might want us to discuss, please send an email to Africa CDC or to ICANN, and we will see how we can try and accommodate that into the series that we build up. Thank you very much for your attention. extension, and thank you for your time spent with us. And here's the encode as well.
Thank you.
Thank you very much, everybody.
Thank you so much, everyone.
Thank you, Vanessa.
Okay, bye-bye.
Bye-bye.
Thank you. Bye.
Thank you, Chimwemwe.
Thank you, everybody.